how does implementation look like when you're doing it within a program, within a hospital system, in a state, within a country, and then internationally? And are there threads that we can learn across all of these that map that we might be able to learn from in order to do our job better? And can we leverage these things? Can we build? Can we scale? How do we build once and support each other and be able to create maybe a union or a collaborative of tools that we can reuse so that we're not all reinventing the wheel? So my name is Nic Encina, for those of you who haven't been paying attention the last 2 days. And then we have here distinguished colleagues that I respect and admire. What I'm going to do is, we have Bethany, who helps run the BabySeq 2 project. We have Carrie, who's helping to run the Beaumont project across Michigan. We have Alice, who helps run the Genomics England program. And we have Dr. Asaf Bitton, who is the executive director of Ariadne Labs. So I'm going to ask them a question and also ask them each to introduce themselves and share a little bit about the program or project that they run. So Bethany, the question I'll ask you, and please introduce yourself and talk about BabySeq. To what extent do you think about your work in terms of scale? And what challenges do you foresee going from a program such as yours into the next level up?
Yeah, thanks, Nick. I'm Bethany Zettler. I'm a genetic counselor, and I'm one of the project managers of the BabySeq project, which you've heard a lot about from Robert and from Ingrid earlier today. So we are, studying genome sequencing as an add-on expansion to newborn screening, like most studies here. But I think something unique about this project is that it is a randomized controlled trial. So we do have a control arm to really robustly measure these outcomes. And we're also doing super comprehensive interpretation of the genome. So we don't even really have a gene list that we're looking at. It's more of reporting criteria. So anything that could present in childhood or potentially be actionable in childhood, we are giving back to the families. So it's a really exciting study. And I'll talk a little bit about how we're thinking about scalability with that. So this project is actually building off of our original BabySeq pilot study, which was in Boston, beginning in about 2015. And so that was a very resource-intensive process, really one of the first studies to generate this kind of evidence, and really, I believe, the first to look at genome sequencing in healthy babies, which was really some exciting preliminary evidence. And so with this next project, we're scaling that up a little bit. So we have funding from NCATS, so the Translational Science Division of NIH, and we're expanding this to 5 different cities across the US. And so we've been able to scale some of our procedures. So we've moved everything to having a virtual option to accommodate more people, make that a little bit easier for the project managers and the participants. We're using less invasive sample types. We're texting participants, we're giving as many options as possible to make this accessible to as many people as possible. But I think the bottom line is that this specific workflow is not likely to be scalable. Again, it's pretty resource intensive. We're reporting back a ton of stuff, so it takes a lot of work to counsel these families. It takes a lot of work to interpret the data and decide what really is reportable for a specific family. So I think there's a lot of valuable data we can get from this project. I think we can get a lot of really rich data from having these conversations with parents, from studying how they react to different types of findings, and really learning what we can find in a healthy genome. So I think that's all really cool data and something that can be added to the collective pool of all of the other amazing studies we've heard about. But I don't think this specific workflow might not be the most scalable for every single baby in the country.
Thank you so much. Carrie, so same to you, please introduce yourself and the project that you're working on. And the question to you is, what sort of obstacles are you seeing when rolling out innovations and learnings from clinical studies like BabySeq and doing so now to frontline clinicians in hospital systems?
Sure, thanks, Nick. So I first came to work with Genomes to People with Robert in 2015, working on the MedSeek project, and we've worked on a lot of projects returning genomic results to healthy people over the last several years. But we've basically decided that there's enough evidence that we feel comfortable doing this in clinical settings and across healthcare systems, which is an exciting time. We're finally here. And at this point, we're really focused on adult populations, but I think the more evidence that we're generating in newborns, the more we're going to be confident that that's going to be a thing in the future. I think right here, this meeting is showing us that. But there are definitely some things to think about. And so my current work is with the Beaumont Health System in Michigan. I'm working with Robert and Nick on the Precision Population Health Program, which is part of Ariadne Labs in Brigham and Women's Hospital. And our whole goal is trying to figure out how to scale genomic sequencing and screening across health systems. So some of the things we're thinking about is how do we educate providers and how do we provide this? So I think some of the early health systems have really leaned on their genetics department. So their genetic counselors are doing a lot. Their geneticists are doing a lot. But how do we get this to a place where primary care providers feel comfortable giving this information to their patients? Do we give them pre-education? Do we just give them just-in-time information, just what you need to know, kind of like the newborn act sheets? And so I think that's one of the big things we need to think about. I also think, depending on the list that you pick, there's not necessarily a lot of guidelines. And so staunch providers want the guidelines. What do the guidelines say I'm going to do? You tell me the result. I want to know what to do about it. And so I think that's not going to be true for a lot of things we're testing for. We're talking about rare disease, even if we're talking about the whole genome. And so I think that's another big thing to consider. The other big thing I'd say is cost, right? Who's going to pay for this? So in these early studies, we're getting health systems or funders to agree that, this is important enough that we need to cover the cost of the test, but that's not going to be forever. I think we're generating the early evidence for that, but we need to figure out what do we really need to do to get funders on board with this? And we've been doing this work for a long time. I think the more evidence we all produce collectively, the more likely they're going to be to start funding these important things. So I think those are some of the big things that come to mind.
Great, thank you. So as we zoom out further on, Alice, same to you. If you could introduce yourself in the program that you lead, although we've heard a lot about Genomics England, so I don't think anybody here is foreign to it. But how do the learnings or challenges, as we're seeing them go from one scale to the next, how does it resonate with you when thinking about how you're doing this across a nation?
Yeah, so hi everyone, I think you're quite familiar from earlier. So I'm the program lead, so a lot of my role is actually the doing of how we're going to do this. I think there's sort of a couple of things that really struck me from today, and one of the things is I think we're all tackling the same design issues. We're all thinking about consent, how we take the samples, how we return information to parents. But I think what we can't forget about is that we'll come up with some very similar solutions in many ways, but also the context we're working in is very different across different countries. I think we talked about the fact earlier that we're very much publicly funded, and that's influencing a lot of our thinking. But even down to, the example I would give is that one of the reasons we're thinking quite carefully about sample type is because in the UK, we take samples on day 5 at home, which means midwives put them dry blood spot cars in their cars on their dashboards to dry them, which means the quality is hugely variable. And it's things like that. That's a local context of the UK, whereas I know in the US, for example, people tend to stay in hospital for 2 days, the samples are taken there. So I think that's something we have to kind of consider as part of these programs, is that we can learn from each other, but also some of it will be a bit different. I think in terms of sort of thinking about the scalability, particularly for us, I think there's kind of sort of 2 or 3 key things that we have to consider working at kind of a larger scale. And that's partly, we talked about earlier, again, the diversity of the types of organisations we have to work with, working across the NHS and different hospitals, which means that we have to design this model in a way that it can work across that diversity. And that means that there is a slight tension for us in kind of the aspects of trying to design something to generate evidence, which is where you want to be as rigid as possible to make sure the evidence is good. But if we're too rigid, it's going to be very hard to then actually run it within that diversity of trusts. And it's trying to kind of find the balance between those 2 things, I think, which is probably a challenge for us in some of our approach.
Excellent, thank you. And so if we take another zoom out, Asaf, same, if you could introduce yourself and your background, and then, as you hear these stories, you've worked in projects from small all the way to international. And so as you hear these stories, what threads do you see, or what learnings have you taken from implementation science, where that we can start kind of incorporating into this field?
Thanks so much. It's really nice to be here. So I'm, in addition to being executive director of Ariadne Labs, which is an implementation science center, I'm a practicing primary care physician and internist. So I think about the questions that are being presented on the panel and your questions all the time in both hats. In the hat of somebody who's a practicing doctor, who's just coming here literally from clinic in Jamaica Plain down the road, to implementing broad multi-country international consortia of innovations or inputs from childbirth, maternal mortality improvement initiatives, to primary care initiatives, to safe surgical initiatives. Ariadne Labs is a joint center at Harvard School of Public Health and Brigham and Women's Hospital for health systems innovation, with really a focus on implementation science. And so, implementation science is one of those things, quite frankly, like precision medicine. It's a buzzword. Who the heck knows what it really means? Let me give you a couple of tangible examples. I come from primary care, so we can't BS. What's the point? How do we go forward? We have a lot of things on our plate, just like you do. So implementation science really is the rigorous study and application of how to translate evidence-based best practices into spread and scale across health systems, across communities, across countries in an equitable way. So an even less wordy way of thinking about it is implementation science is the way in which we understand the gap between what we know we should do across healthcare and what actually happens. That no-do gap, no with a K, is full of enormous and measurable preventable suffering, error, general badness that you've probably experienced across your family's experience with the healthcare public health system. That's also a source of enormous opportunity. And it's animated our work and the work of other people in implementation science to figure out how to marry the best in a clinical or new scientific technology, which, as you said, the evidence, at least by my read, you're the experts, but by my read, we're ready to use this. But the gap between that evidence and clinical practice is vast. And it really requires a partnership that's more than just science. Because what I can tell you from 20 plus years of implementation science is that healthcare innovations, whether they be diagnostics, therapeutics, protocols, policy, healthcare innovations move at the speed of trust. And if you do not have trust with the clinicians and with the patients and families and communities with which you hope with humility to work with, then you have a cute idea that's never going to get off the ground. So our interest is figuring out what are the core parts of implementation science that are broad, that can find really important no-do gaps, which I think this is one in newborn sequencing, and ask the questions, what would it take to then break down that no-do gap and marry this sort of cutting edge of science and clinical care with an implementation modality that's really about pragmatic know-how, no-do. What are we going to do to change behaviors tomorrow? How are we going to build trust? Not tell people what to do, but build trust in this process, that it's fair and that it will bring value to your family and that it will be done with efficacy and with humility. And then how do we not just think about behavior change on the micro level of one by one clinical action, but on the meso and the macro level to scale this? And it's in those scale and spread, they mean two different things, but it's in those spread capacities that we really think about understanding context, as you were saying, but also having a simple enough core idea that you can communicate this to families of all sorts of ranges of health literacy in a way that is understood and in a way that people can make good shared decisions together, and then build the systems on the back end of the clinic, the hospital, the country, the region, to make it easier to do the right thing more of the time. That's kind of what implementation science does.
Thank you. And, now that we got the introductions out of the way, we do want to make this interactive, so there are microphones floating around. So if you ever have questions, please raise your hand. We're not going to wait until the very end. And same for you guys. You have questions to yourselves, but, you guys touched on something really interesting, and it's been a theme that we've covered here today and yesterday on getting adoption. And you mentioned, clinicians, you both did. What do you think is the best way of getting healthcare provider buy-in? And it may be different in the UK versus in the US, but what are the obstacles you're seeing right now and potentially solutions that you're seeing towards getting people to start buying into this? I mean, there's the patient, that's one side, but on the clinician side, they're not looking for new tools, right? And so how do you get buy-in for something like this? Anybody?
I mean, in my opinion, it's what value is it going to bring to my patient? So you have to show them that it's a valuable test. And can I do this easily? Mm-hmm. How can I do this in 5 minutes or less? I'm really busy.
Yeah, I would strongly agree with that. So we have a situation where probably like every health system that, things are in quite a lot of difficult place at the moment, post-COVID, there's a lot of burden on the health system. And it's really thinking about how to do these things in the simplest way where it minimizes the impact on their current workforce and we can really build it in. And I think that's, again, when I sort of talked about how we're trying to get this to work within the NHS, a huge part of that is working out how we can build this into existing processes and pathways. And I think that's really key to people buying into it. I also think you said, it's about understanding what motivates people, and it's different for different parts of the system. People who are dealing with the midwives at the beginning with antenatal care, their kind of interest in this is very different from the clinicians who will be able to see the upfront benefit much more. So it's really understanding what motivates them and what they want to see from a program like this.
That's actually a good point, bringing up the kind of COVID strain. I think one of the things that they're doing at Beaumont that I think will be really interesting to see is whether this type of program can actually motivate primary care doctors to like their job more, because it's new and it's exciting. So as much as it's a burden because it's something new, one of the thoughts is maybe doing something innovative will get them jazzed and excited about their everyday life of providing care to patients. And so I think that's a really novel concept too.
Yeah, and just to sort of add to that, I guess, so for example, one of the things we've been thinking about is like who takes consent permanently, and we've been talking to the people who are in charge of midwifery in the UK, and they can see the really exciting potential for some of the more kind of junior roles of what they call support assistants to become really specialists in this area. So again, it's kind of understanding, like you said, where the innovation could happen and where actually you could bring those two together to kind of inspire people.
Yeah, I would say, make the rote stuff simple and make the hard stuff doable. When by that, in terms of the ordering and the payment policy and the logistics and the hoops through which one must jump, that can be a major barrier to doing the right thing. But once you get beyond that, I just reflect on some of the work that we've done actually in a totally different field that has some connection. And we've done a lot of work in serious illness communication or palliative care. How do you have better conversations with people who are facing a serious or life-limiting disease? And how do you translate those conversations into a set of different actions? Now, some people previously, and this is the crossover to this field, have said, well, what we need to do is we need, 20x more palliative care physicians. Palliative care is so amazing at doing this. Or we need to have enormous credentialed training and train all the oncologists or primary care docs in this. And that's not going to happen. You have to democratize the ability to do a hard thing and make it doable and break it down. And that's, I think, one of my reflections here. And that's what we've done. We've not created a checklist, but worked with the palliative care experts to create a 2-hour training that enables, once a seriously ill patient is identified, enables initially the clinician, and now it's way outside of the physician and the nurse. We're doing this with social workers and community health workers to have a conversation that's useful and valuable with 2 hours or less of training, and document that in the electronic record. So you're maybe asking yourself, why is this guy talking about palliative care? I'm here at a newborn sequencing conference. And the connection that I would offer to you is that you have both the opportunity and need to break down the hard part of having hard conversations, and perhaps even make that streamlined and common. Like, do you all in your various programs, whether on stage or your companies or programs in the audience, need to recreate the wheel around best practices for having shared decision-making conversations with parents. I would argue context is really important. Be very attuned to that, but there are probably some core learnings that maybe a consortium could come together around and then learn from to sort of modify the core and apply the core to a diverse set of contexts. And that really gives the opportunity, I think, to think about how do we make these hard things that after you remove the stupid stuff, the hard thing about, integrating this new testing is really time, yes, payment, yes, but also how do I have a conversation about a multi-generational test that I'm about to offer this family, in which many families, appropriately or not, have big concerns because it has the word genome in it. And so thinking through how we break down those conversations and how we respect and meet patients where they are at, but also maybe push through some barriers or some misunderstandings that people have is a real opportunity.
I love that. And I know we had the social yesterday, and what these events do is bring people together, and you start talking in in hallways and everything. And I know, Alice, you and I were talking about this, and also with Lillian last night about, are there things, and Asaf touched upon it, things that we can do together instead of all reinventing the wheel every single time. And, things like patient communication, clinician training materials, do we each need to invent that ourselves? Our target demographics and populations so different that we need to reinvent that? Or is that something that, by virtue of the consortium that we're building with ICONS, could we just say, okay, let's just agree on what the verbiage and language is, we test it, we build it and write it rigorously, make sure that it actually resonates with populations, test it with patients, and then say, okay, we agree as a consortium that this is what's right, and then open source it so that we can all get access to it? Is that just a fancy and a dream, or is that something that you think we might be able to do? I open it to all of you, but looking at Alice, because we were talking about it last night.
I think it's definitely something we can do, because although I talked about context, as we said, a lot of this stuff, there will be things that we'll all do very similar. And I think you can already see from the presentations today, for example, everyone's thinking about electronic consent. Everyone's thinking about how we layer consent to make it easier and use different media, which I think is, a post probably COVID thing as well, thinking a bit around how we can do this more inventively. And I think sharing what works and what doesn't work and how we've approached those things, I think it's great. I think it'd be brilliant.
I think we can do it to a point. I think that one of the things that's challenging is the diversity factor, the fact that some cultures don't even have a word for genetic, right? And so I think that is the big gap that we're all trying to work on, I think, so hard now, realizing that we haven't done that yet. So I think we can reach most people with shared resources, and then we'll have to try to be creative about some of the things for populations we're still learning how to best support.
So that's interesting. So then, when you think about the diversity, then how do you, to take it now to the more technical side, what are your thoughts about what gene list you use for different population levels? Maybe starting at BabySeq.
Yeah, that's perfect because we don't have a gene list. But no, it's a really important question. And I've really appreciated hearing about all the other studies in this space, because it's something that I've been hearing is this tiered model where you propose, do parents just want the core conditions? Do they want conditions that have a clear treatment? Do they want conditions that might have a treatment down the line, or do they want everything? And I think, we're studying all of these layers. So I do think harmonizing our outcomes is super important. But I think it's also very important to present parents with a choice and trust that they know what's best for their family and what they want to learn, and really respect that, even if it is just the basics.
So I'll take a slightly different tack on it, maybe. So one of the debates we've been having, I guess, around the diversity issue is how we communicate the limitations for certain communities potentially. Because as was raised today, we know that some of the evidence base that this is resting on is predominantly white European. So how are we open and transparent to parents about the fact that for their baby, the evidence may not be as strong or it may not be as clear cut? And I think that's one of the debates we're having. We don't have an answer, but it's something that's very much on our mind at the moment.
Yeah, I think this just came to light because I have just taken on a role of chair of the genetic counseling resource for all of us. And we're talking about VUSs and the fact that all of us is not looking for VUSs in the research result, but if they find in the clinical confirmation piece, they are going to return that information back. And my gut is we don't return VUSs in proactive testing, right? But the counter argument is, well, in these underserved populations, there's way more VUSs. You're just not giving information back. And I don't know what the right answer is for that. I think that that has me uncertain what the right thing to do is. And I think probably why in the beginning with MedSeek, we did decide at some point to return these VUSs that we thought might be a little bit pathogenic, because I think that we still don't have enough data in all the populations to really know what the right answer is for that yet.
Yeah, and we've heard the same thing in BabySeek. We're proactive screening, like only reporting path and likely path. But then we've heard from some of our clinics that serve majority African-American populations, they're like, that's not equitable because we're not going to be getting the same results. Like, that's not fair to our babies.
And the gene list too. So there are certain genes like TTR, which has recently been advocated by some of our colleagues to be added to the American College of Medical Genetics recommended return list because it is more common in African Americans, but it was left out on previous versions of the list. So I think even thinking about the gene list, we have to think about that as well.
I'll ask an artificial question just for the sake of the thought experiment, because we have all these different scale of implementation. If you could, at the level that you're working in, identify the single biggest challenge that you have to implementing your work. And I know there's like dozens and dozens, but if you can narrow it down to one, and then for Asaf, obviously you're not working in newborn sequencing, but when you think about, implementation at scale, what would you say is maybe top of mind, the biggest challenge that you see when implementing things at larger scales? So I'll start maybe with Bethany at your level. Sorry.
It's a really hard question because there's so many. I'd say kind of most top of mind to me right now is the parental buy-in. And we've heard on and on about messaging, but I think the bottom line is this is a paradigm shift in a program that most people don't know exists. And so I think it's going to be hard to get people to see the potential value in that and really, again, trust the system enough to give up their baby's DNA and have genome sequencing. I think that's going to be tough.
I think provider confidence and buy-in, because the provider is that trust that Asaf was talking about. So if the provider is bought into the test and feels like confident that they can explain that to their patient, I think that is going to get the patient on board and really make it happen. But that confidence is lacking. And just, I think it comes along with education and sort of bringing them around. That's what we need to work on.
So I think probably the thing maybe that's on my mind at the moment is the speed at which we deliver our program. So I think the challenge we have is that we want to move fast enough to sort of show that we can deliver this. And also, if you wait too long and wait for perfection, you'll never get anything done. You never learn. However, we also need to bring the UK and the NHS along with us. So it's finding that right balance between moving fast enough, but not moving too fast that we lose everyone along the way.
From a very macro perspective, I guess, and I think it's been stated in the panel a lot, is this issue of context assessment is a particular environment, whether it be, well, first of all, do you know at what level you're implementing? Are you implementing with a provider, at a clinic level, at a health system level, at a trust level, or regional level, at a state-based level, at a national level, or beyond? And at whatever unit you define, are there a set of clearly definable factors that make this ready to implement? Is there leadership buy-in? Is there, and you can say this is Captain Obvious, but I would say back to you, then you should know it and you should measure it. And there are ways to know and measure it. So is there leadership buy-in? Is this not just something that a leader wants and there are resources, number two, for it, but number three, what about the competing priority list? I mean, so, all the time people come to our primary care systems and they have this great idea that they're going to revolutionize medicine with. And, 5 or 10 years ago, the great idea was wearables. And then you get all these companies and all these researchers, we are going to revolutionize. Did you know that we can control blood pressure this way, diabetes that way? And we're just going to measure it and put wearables on their ankles, and and we would say, and what happens when a blood pressure of 256/124 comes in at Sunday night at 3 a.m. or comes in, who's going to accept the data? And by the way, have you looked at burnout within primary care, or have you looked at the fact that we're in a global pandemic? So, knowing your context and understanding what are the sort of competing priorities, not just this should happen, there's a leader that wants it, there's some money behind it, and organizational method for improvement and change, but is this the right time? And that's why we have so much to learn, in heterogeneous, really complex systems like the US that, are very good at piloting, terrible at scaling, have a lot to learn from healthcare systems like the UK, which are, I think, way better at scaling and can teach, because they have methods for actually moving across trust. And maybe you'll tell us that I'm totally wrong on that. But they're knowing when to push and with whom and what that right timing is huge.
So with that, I want to thank the panelists. Hopefully this was thought-provoking. Was there a question?
Yes. I have a colleague who's involved in clinical medical genetics education. She cannot fill 60% of her residency slots. If I understand this, as we move to population or public health basis for these sorts of approaches, you're going to discover, you're not just going to diagnose everything that's out there, you're going to increase what could be diagnosed. And that's going to lead to stresses on a system that's not already fully staffed. Is anybody measuring this quantitatively and modeling it and thinking about solutions?
So I guess sort of from a UK perspective, we have a similar issue. So we're sort of thinking about it in two ways. One is thinking about the pipeline, and this is kind of relates to how you do things at scale, and working out how we can kind of reduce the manual impact by thinking about things like algorithms and more kind of automated approaches. I think the other thing as well is making sure that's really strong party evaluations. That's also partly the thing we're thinking very carefully about, is how do we measure and understand the workforce that we need to deliver this? And that would be part of what we'll give over to the NHS and to the National Screening Committee, who will make the decisions around this, to be able to say this is what you would need and this is what the impact is.
I've been hearing this about the medical genetics community for a decade now, so I know they're working on it, but I know it's not getting better fast. My gut is that it's going to go more to the genetic counselors, similarly to how primary care is going more to physician assistants. I'm not saying that's the right answer. We have different skill sets, and I think we need both. But I think that we're going to need to lean more heavily on a workforce that's a little bit more staffed until that problem can be fixed. And I suspect some of that issue is kind of in reimbursement for services, which is an issue with the U.S. healthcare system at large, I think.
Yeah, I also think that, just taking a step back, like genomics is here as part of medicine. And I do think as part of like the general medical training, they should learn a little bit more about genetics, because it's going to be more and more important. And then maybe we don't need quite as many medical geneticists if every doctor can handle a little bit.
I think that's so important. I think about, Robert and I have talked about this over the years, that 20 years ago, the idea, at least in the US, of primary care physicians ordering MRIs, you'd have to go through these layers of approval. What's a primary care doc ordering an MRI? She doesn't know, or he doesn't know how to interpret such a reified, complex tool. What if we find some equivalents of VUSs, incidentalomas, we call them in MRI imaging. And, now it's kind of like, you would never even think that primary care wouldn't order an MRI except for utilization management. But the point being, and I think this is opportunity for genetics is we in primary care and pediatrics can order tests at a drop of a hat right now that are as or more powerful than genomic sequencing, and yet we're sort of still, for some appropriate reasons and some maybe opportunities to move past barrier reasons, hung up on the specifics of what genomic screening might mean. And so I think part of it is education. Part of it is the use of effective digital clinical tools. There are a bunch that clinicians use every day to make them quite frankly, much smarter than they otherwise would be, and able to interpret really complex tests, especially in primary care, in areas that you're not a specialist in. So there's a way around it. We'll still need lots of geneticists and lots of genetic counselors, but you can change the word. Change the word geneticist for we need more psychiatrists. We need more palliative care docs. We need more, there are a bunch of specialties that we're not going to train our way into that need. And so it's about democratizing and building effective protocols with communities to find smarter ways to scale this technology.
Great way to end it. I thank you all so much. It's a lot of fun. Thank you.